Good morning, everyone. I am Guido. I'm very pleased to talk to you about long-term consequences of peritoneal dialysis in children. Next slide, please. Um, I've been asked to talk about histopathological changes of long-term peritoneal dialysis using physiologic solutions, and I am very grateful for this invitation. Next slide, please. I have no financial relationships to disclose relevant to my presentation. Next slide, please. And I'm hoping that at the end of this session, you will be able to understand the need for more physiologic PD solutions in children and adolescents, know the peritoneal membrane characteristics by age, appreciate the pH trauma caused by conventional solutions, and learn about thickening of the peritoneum after long-term PD, even when using physiologic solutions. Next. So, most of you are adult nephrologists and may not be appreciating the special considerations that you have to do when you prescribe PD to children. First, there's a very different epidemiology. Then what are the age distributions? What are the sizes, access, peritoneal membrane characteristics, etc.? All of that influences the dialysis prescription. Next. So what are the children that we're dialyzing? Obviously, they're much smaller in numbers than our adult colleagues. Next. There are huge differences in the rate per million population. Very high rates, for instance, in Finland because of congenital nephrotic syndrome of the Finnish type. Here in North America, we're sort of in the middle of the field. That's on the right side. And then there is also a huge difference in the choice of treatment period. If I disclose the bias in our center, we would put every child and every adolescent on PD as our first choice. Only a small fraction on home hemodialysis, and only if we absolutely must do, we would choose in-center hemodialysis. This has in part to do with the fact that there are patients that are over 1,000 miles away from us. Next slide, please. So what are the ages? We do dialyze very young babies. They usually have structural anomalies and underdosing of the nephrons, but the bulk are around age 12 to 19. And as you can see, that is pretty much matched with other countries like Japan or the United States of America. Next. So what are the membrane characteristics of children? So here's a significant difference. The younger they are, the more they are high transporters, and a very large proportion of them are high or high average transporters. Next slide, please. So you can, of course, determine what type of membrane you have with a peritoneal equilibration test. We do the standard 4-hour test, and we are obviously looking at the disappearance of glucose and of the increase in the PD fluid with creatinine and urea. And as you all know, there are 4 types: fast, fast average, slow average, and slow. And in children, next, the characteristics of the membrane really vary by age. Here's a cartoon that's adapted by the paper from Brett Warady. The black bars are the the appearance of creatinine in the fluid, and you can see that the older they are, the lower the DP. And then when you look at the glucose, then the younger they are, the faster they assimilate the glucose. So any young children, we would definitely put on PD with CCPD. Next. Here's another way of looking at this, which we published in our own group. We looked at the disappearance of icodextrin and looked at the ability to do net fluid removal, and the disappearance of the icodextrin is very, very rapid in young children, and then approaches more normal adult values when you're later in adolescence. And this has been shown by other centers as well. Next. So as you know, when you have a fast transport membrane, then you have pretty good solute clearance, but you don't have very good ultrafiltration. And most often we really have to remove a lot of fluid. So as a consequence, we prescribe CCPD with 1 hour cycles. Next. So what are the consequences of long-term peritoneal dialysis? Well, when you look at non-physiologic solutions, there is a low pH, which is necessary to avoid the glucose degradation products. Next. And this is a problem because with CCPD, as I will show you, there is no time to equilibrate the pH. Only bicarbonate peritoneal dialysis solution don't cause a pH trauma, but it does take at least 1 hour to equilibrate the pH. And since most children are high transporters, during the 1 hour cycles, it will never equilibrate, and we should be using the physiologic solutions such as Bicavera or Physiologic, but they're more expensive because the bicarbonate gas is out and it's expensive to make those plastic bags. And in very advanced countries like the United States, for instance, these are actually not available. We've been very fortunate in Ontario. We have had Physiologic approved since 1999. Next slide, please. So the conventional solutions have been proven to be safe and effective, but it is accepted now that the composition is not ideal. And the high lactate concentration found in the low pH environment with the pH, which is typically around 5.2 to 5.5, you do avoid or reduce the degradation products, glucose degradation products during the heat sterilization, but it is a pH trauma. Next. And here are just some examples on electron microscopy studies. So the microvilli of mesothelial cells are fine and long in a healthy peritoneum. Next slide. After just 20 days of PD with conventional solutions, there are significant changes. There's a marked reduction of the microvilli. There is vacuolization of cells near the basement membrane, which is probably a sign of early detachment. And next, if you have long-term, after 14 months, for instance, then there's a total absence of the microvilli. And you may appreciate that there's actually some beginning thickening. Next. The end product of this could be a very devastating disease, namely sclerosing peritonitis, which is basically an encapsulating peritonitis of both the visceral and the parietal layers of the peritoneum, leading to an inability of the gut to move, and if untreated, would be fatal. Next. So, unfortunately, with PD in children, the latest after sort of 6 or 7 years of peritoneal dialysis, you see a significant reduction in the ultrafiltration. You see angiogenesis and vasculopathy, and even sclerosis, which has a high morbidity and mortality. Next. So this is experience from before I moved to Canada in 1999, and not having had access to the physiologic solutions. We dialyzed 71 patients with peritoneal dialysis with conventional solution. Mean age was 10 years, and the mean age of the PD was actually only 12 months. But we had, in most cases, then fortunately been able to transplant them. 11 had to be converted to hemodialysis, and 3 were dead, unfortunately, and the leading cause was sclerosing peritonitis. Next. So the 13 of these patients had complications. 3 had latex allergies and lost their catheters. There was 1 peritoneal pleural fistula, 4 had candida peritonitis, and 5 actually were diagnosed with sclerosing peritonitis. So 2 were successfully treated surgically after transplantation, and of course they had a longer period of peritoneal dialysis, but they had no association with peritonitis. Next. So here is a very compassionate plea to use physiologic solutions in children. Next. So the longer you dialyze, the more you get a thickening of the peritoneum and the higher the prevalence of vasculopathy. Next. And here you can see the evolution over time. From that normal appearance, you get the medial layer thickening over time, and you get this massive angiogenesis. And these are actually signs of sclerosing peritonitis. Next. So here you can see the histological differences, and please bear this in mind as we're going to show you a histology of a child on very long-term PD on physiologic solutions later on. Next. So the glucose degradation product avoidance is the main reason for this to happen, and for instance, formaldehyde can't be very good. So that is really the main reason why the heat sterilization process requires the pH to be low. Next. And as we learned, there is obviously a problem with the pH equilibration. And here you can see the difference between a conventional and a physiologic solution. You'd actually never expose the patient to pH trauma. Next. So, as I told you, most of the patients needed CCPD, and as you can see, except for the last dwell, which in our case we actually do very often with icodextrin, there is no normalization of the pH happening at all. Next. So the solution is that you still do the heat sterilization of the glucose-containing bag part with a low pH, but then you have a second bag that has a bicarbonate-based solution, and then you mix them before you actually use it on the patient to then achieve the pH that you desire, which should be between 6.5 and 7.4. Next. So this is basically the idea of the bags that we are using in our center, right? And you quickly break this before, and then the solution swirls in and has a physiologic solution afterwards. Next. So what are the differences? The calcium concentration, sodium concentration, magnesium concentration, and chloride concentration are the same, as is the glucose and the osmolarity. But the main difference is that the pH is 2 pH units higher, and that there's much less lactate and much more bicarbonate in the solution. Next. So there are no data published on what happens with long-term peritoneal dialysis when you use physiologic solution. The literature is very scant. Next. So we had the opportunity to study this in a girl who is on peritoneal dialysis for a very long time. She was diagnosed with focal and segmental glomerular sclerosis at age 6, at age 7.5. Unfortunately, she got a TMA. It was an atypical bug, but it was a classic HUS. And unfortunately, very quickly, within less than 2 years, she developed end-stage chronic kidney disease. We started with CCPD, using the recommended 1,000 to 1,100 milliliters per meter squared for 10 hours, and then had a last fill of icodextrin. A year later, she unfortunately lost her first transplant with immediate recurrence of the FSGS. She then developed, after restarting PD, a peritoneal pericardial fistula, which closed thereafter, and then we put her back on PD for another 5 years. Very similar solutions, although we did have a little bit of loss of ultrafiltration and had to use more 2.27% rather than 1.36% physiologic. At age 14, she underwent a second transplant, and unfortunately, there was again immediate recurrence of the FSGS. And fortunately, she responded somewhat to rescue therapy with LDL apheresis and high-dose methylprednisolone, and the GFR recovered from anuria to about 25 milliliter. Unfortunately, then, 3 months later, she was diagnosed with a pretty strong BK virus nephropathy with more than 20 million copies in the peripheral blood, and she had slow deterioration, but we are approaching 2 years after the second transplant, and her GFR is about 18, and she does not need dialysis yet. So to plan the dialysis again, we put in a PD catheter. Next slide, please. And this is the last PET, so she's still a high transporter, a very high transporter. Next. We asked the surgeon who put the catheter in to do two things: to do a very detailed inspection of the peritoneum in a laparoscopic approach, and to also obtain a biopsy because of the lack of data of what would happen after such a long time. And there were a few of these very bright plaques, which presumably are some areas of fibrosis, but overall, the peritoneal membrane actually looked pretty good. Next. The histology, however, was absolutely not normal. This is here a comparison, 400 micrometers. Then you can see there's quite a thick peritoneal layer, similar to what I showed you on the non-physiologic solutions. So next, what is actually the normal membrane thickness? So I don't know how many of you know that there's an age dependency. And the thickest membranes are actually seen in the age of the patient when we did the biopsy. But even if you take the 95th percentile, it's 495 in her age group, and she had 600 to 650, in some areas even 900 micrometers. Next slide, please. So this is a table of the thickness again. So she was 14, even 540, if we go all the way to the top, is well less than what we measured in her peritoneum. Next slide, please. So here are trichrome stains and others. As you can see, there's a deep layer where the arteries are. There was actually not an increased vascularization, so no evidence for sclerosing peritonitis, but the immediate layer was quite a bit thickened, and the superficial layer was devoid of the microvilli as well. And here's another stain that was interesting because there was a need for IV iron for some part of her peritoneal dialysis. And even though her ferritin was normal at the time of this, there was considerable hemosiderosis. Next. So here's the report from the histology. There were sections that show fragments of the peritoneum with overlying mesothelium. There is fibrosis and thickening of the submesothelial tissue with significant hemosiderin deposition, as highlighted with the Pearl's Prussian blue histochemical staining. Measurements of the submesothelial compact zone are difficult to do due to tangential orientation. However, the oriented section, the thickness is all the way up to 900 micrometers. The overlying mesothelial cells are intact. There was no denudation. There's a lack of fibrin exudation or fibroblast proliferation, no increased inflammation, no calcification is identified, and no new membrane formation or vascular obliteration occurred. So the diagnosis was peritoneal fibrosis and hemosiderosis, non-specific, but no encapsulating peritoneal sclerosis. Next slide, please. So to conclude, despite physiologic solutions and 14-hour no glucose exposure every single night, after 6 years of PD, widespread peritoneal fibrosis was seen, but we did not find any evidence for EPS. And actually, literature suggests that that is really receding with the use of physiologic solution. So the Conclusions from our end is that the currently available physiologic solutions may not be sufficient to preserve the peritoneum, and that continual efforts are needed to develop PD solutions that are more efficient and gentler to the peritoneal membrane. Next. Thank you very much for your attention, and I'm happy to take any questions.